Hi everybody, welcome to part one of two presentations on the facial bones focused on facial bone trauma. So first of all, we'll have a look at each of the projections and what the normal anatomical appearances should be, and then we'll have a look at orbital rim fractures, and then we'll look at the Zygomatico-maxillary complex. Here we have the OM view. You can see that because the petrous ridges are on the lower border of the maxillary antra. In this particular case, the mouth is open, so technically this is a Waters view, but nevertheless, take a look at the anatomy, remind yourself where everything should be, and then pause the video if you wish, or just let it run and we'll continue. And here we have the occipital mental 30, the OM30. Again, just refresh your knowledge of the anatomy. Pause the video if you wish, otherwise let it run and we'll move on. And here we have the coned SMV focused just onto the face rather than the whole skull. The so-called Jug Handles View. Again, just remind yourself about the anatomy. Pause the video if you wish, otherwise let it run and we'll move on. And here we have the lateral view. Not normally done for facial bones, it's fair to say, in a trauma situation. Nevertheless, take a look, make sure you know where the anatomy is.
McGrigor Lines. McGrigor Lines are very good at assessing disruption, but it's important to understand that if you don't have a displaced fracture, i.e. you have an undisplaced fracture, then unless you search the cortices carefully, you will miss them. So don't just fall into the trap of just assessing for disruption, search actively for undisplaced fractures. So McGrigor lines are slightly more advanced than Dolan's lines in that there are 3 rather than just 2. And the superior line, line 1, starts at the frontozygomatic suture, running over the superior orbital rim, over the glabella, and over the opposing side. And as you can imagine, it's very good at assessing for diastasis of the frontozygomatic suture. Fractures to the superior orbital rim. If the patient has a frontal sinus, to assess for an air fluid level within that. Remember, sinus pathology can present with an air fluid level. So an air fluid level does not necessarily indicate that there is definitely a fracture. The other thing that's very helpful with line 1 is that it allows you to search carefully for a black eyebrow sign. Black eyebrow sign. So black eyebrow sign is orbital emphysema. Emphysema means air, so it's air trapped within the orbit. If you see a black eyebrow sign, then you know the patient has to have sustained a fracture that communicates with a sinus, because the air has escaped out of the sinus and has migrated into the superior aspect of the orbit, creating this black eyebrow appearance. Now line 2, we go over the superior border of the zygoma, of the zygomatic body, over the infraorbital margin, up over the medial aspect of the nose, assessing for nasoethmoidal fractures, and out the opposing side. So with this particular one, it's good to assess for disruption to the zygoma and to the infraorbital margin particularly. Search very carefully for a soft tissue opacity that is seen inferior to the infraorbital margin, and this represents herniation of the orbital contents, which happens or which may occur with a blowout fracture. So with our lower line, we go over the inferior margin of the zygomatic arch. Be careful, you can get small bumps here which are completely normal and should be a normal variant, and they shouldn't be mistaken for abnormality. So you pass down the lateral wall of your maxilla, assessing for fractures over the border of the teeth and up over the opposing side, assessing for fractures to the alveolar ridge. Check for fluid levels. The biggest problem with McGrigor lines is that we don't deliberately assess the medial margin of the maxilla. And so I'd like you to really concentrate that when you assess your face, that you deliberately, strategically make sure that you look at this area, because you may see a fracture through here. Don't forget to check your mandible. Now with our OM30 view, as you can appreciate, we can't clearly visualise our orbits, so that's why it's not very good for assessing that. And you can see how the patient's head markedly tilting, and so with the conical shape of the maxillary antra, you can appreciate how the fluid level can move posteriorly, so we don't appreciate it. However, line 2 provides good visualization of the infraorbital margin, and we clearly see the lateral border of the maxilla, so the alveolar ridge. Make sure that you count down here as well. This is the medial borders. Check your mandible. Okay, let's move on. So when assessing for facial injuries, what radiographic signs do we look for? We look for direct signs with non-anatomic linear lucencies. It's important to familiarise yourself with what a normal facial bone x-ray looks like. Get used to the overlapping structures creating different densities, which can be tricky when it comes to image interpretation. Look for cortical defects or diastatic sutures. Check for overlapping bone fragments creating a double density, and look for asymmetry of the face. So indirect signs include soft tissue swelling. Remember, be careful, don't mistake the eyelids in particular and the soft tissues of the cheek for periorbital swelling. Look for periorbital or intracranial air, and check for fluid in the paranasal sinuses. So the face has 3 areas of strength: the alveolar process of the maxilla, the frontal process of the maxilla, and the body of the zygoma. So when you search for fractures, concentrate at the boundaries. So the frontal process of the zygoma, the zygomatic arch, the infraorbital rim, the lateral wall of the maxillary sinuses, medial wall of the orbits in the region of the nasion, and as ever, symmetry is usual, asymmetry is unusual. So if you have asymmetry, search carefully. Unsurprisingly, Most injuries occur from motor vehicle accidents, although airbags have significantly helped reduce these injuries. Fights and assaults. And the most common fracture that you get to the midface is the Zygomatico-maxillary complex fracture, the ZMC fracture. You can also get isolated zygomatic arch fractures, and then more complex fractures, the LaFour injury classification. Interestingly, facial injuries don't really occur in pediatrics very much. It's probably because the face isn't very prominent when you're a child, and less than 10% of these injuries occur in pediatrics. And usually when they do sustain an injury, it's going to be to the condyles of the maxilla. So you will appreciate those on your OPG view. So we have an OM view. A is for adequate. I certainly wouldn't repeat this image. It's pretty straight. And the petrous ridges are at the inferior aspects of the maxillary antra, which is fine. So we can quite clearly see the maxillary floor there, not a problem. So I wouldn't repeat this. I'd say this is adequate. Now, if we use McGrigor's lines, then we are assessing for alignment, bones, cartilage and soft tissues all at once. So let's do McGrigor's lines. Line 1, so we start at the frontozygomatic suture over the superior margin of the orbit, over the glabella, over the opposing side and the opposing frontozygomatic suture. So is there diastasis of the frontozygomatic suture? No. Is there a fracture to the superior orbital rim? No. Is there an air fluid level in the frontal sinus? No, there's normal aeration. And is there a black eyebrow sign caused by orbital emphysema? No. Okay, so let's move on to line 2. So we go over the superior orbital margin, over the body, over the infraorbital margin, up over the medial wall of the orbit and nasion, and up over down around the opposing side. And it's at this point, can you see that lucency there? That is a step in the infraorbital margin. Remember, this is the infraorbital margin. So this is a step in the infraorbital margin. This is not a fracture of the orbital floor. That's very important. We cannot visualize the orbital floor on an OM or an OM30 view. So if you have a blowout fracture, which is a fracture to the orbital floor, you are looking for that soft tissue sign, the teardrop sign, which is the herniation of the orbit into the antrum below, which we don't have. So an orbital rim fracture here is not the same as an orbital floor fracture. Very, very important. So we don't have a fracture of the zygomatic arch or the body. We have sustained a fracture to the left infraorbital margin, but we don't have evidence of a teardrop sign. Line 3, we go for the inferior aspect of the zygoma, down the lateral maxillary antra, over the alveolar ridge and up over the opposing side. So this appears to be all good. So the maxillary antra have been preserved and the zygomatic arches are preserved. Remember, McGrigor's lines don't check the medial aspect. This is normal. What do we have to assess for? Now we have to assess for an air fluid level within the maxillary sinus. And we can quite clearly see there's a pacification of the left maxillary antra, which will be due to the fracture to the infraorbital margin. I admit there's soft tissue pacification here. This is sinus disease, nothing for you to worry about. Don't worry about that. We won't show you anything like that in the exam. Okay, just quickly check your mandible. Anything else that's going along? Okay, all good. So we've assessed for alignment. We've assessed the bones. We've assessed the cartilage, i.e. the frontozygomatic suture. And we've assessed the soft tissues. So let's move on. So what is it? It's a fracture. Where is it? Left infraorbital margin. How? Minimal displacement, fluid in the left maxillary antrum. Blowout fractures. So as I've said before, the blowout fracture occurs to the orbital floor. Now, the injury, what happens with this particular injury is that generally people sustain a direct blow to the orbit. So this raises the pressure within the orbit, and the orbital floor is actually very weak. So what happens is that the pressure rises and causes a blowout to the floor of the orbit. And what can happen is that the orbital contents can herniate down through that fracture. So because we can't see an orbital floor fracture, we're looking for either a teardrop sign, which is our soft tissue pacification of the orbital contents herniating down into the maxillary antra. You may occasionally get a tiny fracture fragment within the maxillary antra, which is a detached fragment from the orbital floor. If you're going to see any part of the fracture, that would be the only bit you see. But classically, you get the soft tissue opacification or teardrop sign. And you often get an associated fluid level. So here we have a lovely Waters view. We can tell it's a Waters view because the patient's mouth is open, allowing us to visualize the sphenoid sinus. So you've got here frontal sinus, and down here these are your ethmoid sinuses. So your ethmoid sinuses lie anterior to the sphenoid sinus, and so therefore they're superimposed. That's why you open the mouth. We can tell it's an OM view because the orbits are beautifully visualized, and we can see that the petrous ridge is just lying inferior to our maxillary antra. The patient is straight, so A, this is a very adequate image. Okay, line 1. So we start at the frontozygomatic suture, up over the superior orbital rim, over our nasion, over the opposing side, ending at the opposing frontozygomatic suture. So there's no diastasis of the frontozygomatic suture. There's no fracture to the superior orbital margin. Our frontal sinus is normally aerated with no air fluid level. There's no black eyebrow sign, indicating that there is there's been orbital emphysema. Line 2. So we go over the superior aspect of the zygoma, over the infraorbital margin, up over the medial borders of the orbit, over the nasion, down the opposing side. So we can see no fracture. But if we look carefully, we can see a soft tissue opacification, and that has to be caused by the herniation of the orbital contents into the maxillary antra. So we have a positive sign here indicating there is an undisplaced fracture. Line 3. Inferior aspect of the zygoma. Can remember those little tug angles? You can get that, that's quite normal, nothing to worry about. Down the lateral margin of the maxillary antra, over the alveolar ridge, up over the opposing side. Check your medial borders of your maxillary antra, but this is all good. Okay, so your bones are good. We can clearly see there is a fluid level within the right maxillary antra, which corresponds to the same side as the teardrop sign. Okay, let's move on. So what is it? It's a fracture blowout. Where? Right orbital floor. How? Teardrop sign, fluid in the right maxillary antrum. So we've talked about blowout fractures. That's when a direct blow to the orbit raises the pressure within the orbital cavity and it causes a fracture at the weakest point, which is our orbital floor. The orbital floor is not visualised on an OM or an OM30 view. But what can happen is that you can get herniation of the orbital contents through the fracture, and what we're looking for is a teardrop sign, which is soft tissue opacification, just inferior to the infraorbital margin, indicating that there is a blowout fracture. Now, occasionally we get a black eyebrow sign. So the orbital floor fracture communicates with the maxillary sinus. The sinus contains air. So what happens is that air escapes from the maxillary sinus and it then migrates to lie on the inferior to the superior orbital margin, creating the appearance of a black eyebrow. Remember, air is black on an X-ray. So it is possible to get orbital emphysema and a teardrop sign on the same image. So you can have a black eyebrow, orbital emphysema by itself, or you can have a black eyebrow sign and a teardrop sign, or you can have just a soft tissue teardrop sign. So it could be any one of those three combinations. But let's have a quick look at this X-ray. So A is adequate. Well, no, it really isn't, is it? It's really rather rotated. And the petrous ridges are quite clearly within the maxillary sinus. So if this was me, I would definitely be repeating this image. But the purpose of this X-ray is to serve a function, so we'll just crack on. So line 1. We look for the fronto-zygomatic suture up over the superior orbital margin, over the glabella, over the superior orbital margin, over the fronto-zygomatic suture. So, is there diastasis of the fronto-zygomatic suture? No. Is there a fracture to the superior orbital margin? No. Is there air fluid level within the frontal sinus? No, the frontal sinus is normal aeration. Is there a black eyebrow sign? Yes, bingo. So we can quite clearly see this dark black area just inferior to the superior orbital margin, indicating that there is air trapped within the orbit, creating the appearance of a black eyebrow sign. So therefore, this patient must have sustained a blowout fracture because there is air that has escaped from the sinus and has now become entrapped within the orbit. Line 2, superior aspect of the zygomatic arch of the body, over the infraorbital margin, up over the medial wall, over the nasion, down the opposing side. Okay, is there a fracture to the zygoma? Is there a fracture to the infraorbital margin? Can you see any displacement to the lateral, to the medial borders of the orbits? No, no, no. Do you have a soft tissue opacification just inferior to the infraorbital margin, consistent with the teardrop sign? No. So line 2 is normal. Line 3. So we go for the inferior margin, along the lateral borders of the maxilla, along the alveolar ridge, along the lateral borders of the maxilla, over the inferior border of the zygoma. Just have a quick look at your medial borders, have a quick look all around here, just quickly have a look at your mandible, the skull. Okay, so line 3. Is there a fracture of the zygoma? No. Is there a fracture of the lateral wall of the maxilla? No. Is there a fracture of the medial wall of the maxilla? No. Is there a fracture through the alveolar ridge? No. Do you have a fluid level within the maxillary antra? No. This is normal. So on this view only, we have one positive sign, the black eyebrow sign, which is consistent with orbital emphysema. Now I just want to compare this patient with the previous patient. So here on our left, we can quite clearly see our orbital emphysema. Now look at our Waters view on our right. Can you see this dark, but not as dark as the air, this black curvature? This is periglobal fat. This is normal. And you can see the globes here of the eyes, and the fat accumulates in the eyelid region, so you get periglobal fat. Peri around, global pertaining to the globe, periglobal fat. It's of a similar density bilaterally, so you can use that to help you when assessing whether it's an orbital emphysema or if it's just periglobal fat. So just something to be aware of. So what is it? It's a blowout fracture. Where? Right orbit. How? Infraorbital emphysema, black eyebrow sign. The Zygomatico-maxillary complex fracture, the ZMC fracture, is a very common injury. You need to know this. It's usually caused by a blow to the malar eminence. And the principal lines of fracture involve 3 very distinct components. So you're looking at the orbital process, the zygomatic arch, and the inferior orbital rim, the infraorbital rim. Now the term tripod fracture is an old term, and it refers to the fact that they usually are, it's the 3 limbs that support the body of the zygoma are broken. But today we call it a Zygomatico-maxillary complex fracture, a ZMC fracture. So usually what you get a separation, you get diastasis of the frontozygomatic suture. You get a fracture of the infraorbital rim medially, and it's usually in the area of the zygomaxillary suture. And then you get a separate fracture of the zygomatic arch, either posteriorly or in the region of the zygomatico-temporal suture. Okay, zygomatico-maxillary complex fracture. A is for adequate. The OM view It's not particularly rotated, so it's a little bit rotated, but not significantly so. The petrous ridges are projected inferior to the maxillary antrum, so A for the OM view is adequate. Okay, line 1. We start at the frontozygomatic suture, over the superior margin of the orbit, over the glabella, over the opposing superior margin of the orbit, and here quite clearly we can see a disruption to the frontozygomatic suture on the left. Look at the right, there's alignment, there's no diastasis at all of the suture. We can see that the suture has completely separated, so we have an abnormal suture on the left. So abnormal suture, frontozygomatic suture. Do we have a fracture through the superior orbital margin? No. Do we have an air fluid level in the frontal sinus? No, we have normal aeration. Do we have a black eyebrow sign? No. Line 2. So we go over the superior margin of the zygoma, up over the infraorbital margin, over the medial border of the orbital wall, up over the nasion, down the opposing side. Oh, look at this. There is a big, so if you can look at this, look at the right orbital margin, look at the left infraorbital margin. There is a step in the cortex. There is a marked displacement of the infraorbital margin on the left. So we've got a diastasis of the frontozygomatic suture. We've got a big step in the margin of the infraorbital margin. Let's keep going. Over the zygomatic arch, and we can quite clearly see there's a lytic line indicating there is a fracture through the zygomatic arch. So we've got a fracture of we've got diastasis of the frontozygomatic suture, we've got a displaced fracture of the infraorbital margin, we've got an isolated fracture of the zygomatic arch. 1, 2, 3. Okay. Do we have a teardrop sign on the left? No. Can't really see what's going on here at the moment. Number 3. Down the inferior margin, down the lateral margin of the maxilla, over the alveolar ridge, and through to the other side. We can now see lots of increased density. There is disruption to the lateral wall of the maxilla. So we've got a 4th injury. So this is in fact involves all the way through the maxilla. So the infraorbital margin that extends out to the lateral maxillary wall. Over and the inferior margin, we can again see the infraorbital fracture, the fracture to the zygomatic arch. So we've got 1 injury, 2 injury, which extends down to here. So that's 3, 4. 1, 2, 3, 4. We've got a fluid level within the maxillary sinus, unsurprisingly. Let's just have a quick look. Yeah, that's fine. Nice bit of the peg. That's a quick look at that. That's fine. Okay. Please take off artefacts, particularly in for facial bones, as well as dentures. That would be really helpful. Okay, let's look at our OM view. Okay, so with our OM view, soft tissue signs now. Can you see on the right we have a marked soft tissue sign. Look at the left. There's no soft tissue swelling at all. So we've got marked soft tissue swelling on the left. OM30 adequate, a little bit rotated, but we can clearly see what the issue is, and the petrous ridges are well projected from the maxillary sinus. So yes, I accept this. So over the superior margin, look at that. That's a nice view of the infraorbital margin over the nasion, medial border, nasion. Big step. Look at that. There's even comminution to it. It's an absolute marked step to the infraorbital margin. We can see the fracture through here. There we go. Look at the inferior orbital margin, and here we can see real smashed, completely smashed in. So the OM30 view is much better at looking at the lateral aspect of the maxillary sinus. Just quickly have a check of the maxilla. Oh, sorry, not the maxilla, the mandible. Okay, great. Let's carry on. So Zygomatico-maxillary complex fracture. So what is it? It's a fracture and diastasis. So diastasis is a term that we use particularly with fibrous joints, such as sutures and synchondroses. So think about sutures in the skull. Think about the synchondrosis of the symphysis pubis. Think about the SI joint. So particularly with those joints, when we describe disruption, we refer to it as diastasis. So diastasis is when it separates, it moves apart. So we have a fracture and diastasis. So it's a zygomatico-maxillary complex fracture where left maxilla, zygoma, and frontozygomatic suture. How? Slight displacement, fluid in the left maxillary antrum. So fractures of the zygomatic arch, they're not as common as you think they might be, usually by a direct blow. And commonly they tend to consist of 3 fractures. So you tend to get a fracture at each extremity. And then what happens is you tend to get a 3rd fracture, which usually occurs at the temporozygomatic suture, and that happens with depression of the fracture fragments. A is adequate. Well, the patient is tilted to the right, but not rotated, and this SMV beautifully throws off the zygomatic arches. So they're clearly thrown away from the rest of the face. So this is a lovely picture. So when I said classically they tend to break in 3 parts, obviously the rule of thumb does not always apply. So with this particular patient, we've got sustained 2 fractures. So you've got a fracture at the distal portion of the zygomatic arch, and you've got a fracture through the middle portion, which is basically the temporozygomatic suture. And then what's happened is that it's created a depression of the fracture fragment. So it has been depressed, it is pushed in towards the face. So what is it? It's a fracture where right zygomatic arch. How? Comminuted with depression. Okay, we've reached the end of part 1 of the facial bones, and I look forward to chatting to you for part 2. See you soon.